Hi everybody, this is another video about vitamin D receptor resistance. Just before I get into the crux of the video, just as per usual, nothing that I'm saying should be construed as medical advice. If you need medical advice, please talk to your personal healthcare provider. This is for informational purposes only. So I've posted a couple of videos now about vitamin D receptor resistance. I think it's a very cool thing, really good thing to know about. I've been seeing the treatment effects of addressing this in patients, a growing number of patients, and definitely thinking this is something that's going to be in my tool belt on my tool belt for the long term, because I've been quite excited about it. I think it helps to explain a lot of the underlying pathophysiology of a number of cases I've been seeing over the years. So one of the questions that were posted on one of my videos about vitamin D receptor resistance was, so it says, so increased parathyroid hormone levels with normal vitamin D levels are the way to diagnose vitamin D resistance. What about scenarios where parathyroid hormone is elevated for different reasons while the vitamin is normal? It's a good question. There certainly could be certain pathologies where parathyroid hormone is elevated for other reasons, and to my understanding, that would be a case where we really wouldn't be able to use the parathyroid hormone level as a barometer of vitamin D receptor function. So I think that probably precludes the use of it in those cases. With that being said, if I had a case like that, which I haven't encountered that yet, parathyroid hormone abnormalities for other reasons are relatively rare, at least in my practice, I'd probably consult with somebody who knows more about it than me and try to get a better answer, but I think it might prevent us from using that metric in those types of cases. Next question is, in the presence of autoimmune disease, why not supplement with high-dose vitamin D anyway? That's a really good question. Historically, that's generally been my practice, to encourage patients to pursue that type of intervention, because just clinically it seems to be helpful for folks with autoimmunity in general. Now, generally, what I would have considered high dose before is not nearly as high dose as some patients seem to need to go to overcome this vitamin D receptor resistance. I think the reason that I would personally, the reason that I do advocate testing rather than say to patients, why don't you go pursue high-dose vitamin D protocols without testing first, is because if a patient doesn't need that much vitamin D, do we want to be putting our eggs in that basket and just asking their body to process some vitamin D that it doesn't otherwise need? And then also, well, I do believe, from what I've seen from the research literature and what I've observed in practice, that robust doses of vitamin D are oftentimes very safe. I mean, to my understanding, looking at the research literature, and for anyone interested, there was this 2016 review article looking at the case reports leading up to that point. Like, I think the first ones were started back in the 80s. Case reports of folks who were experiencing vitamin D toxicity. Relatively speaking, over that 40 some odd year period that that review covers, quite a small number of cases of vitamin D toxicity, and generally the symptoms were, or vitamin D toxicity was not reported in anyone taking less than 50,000 international units a day, generally for several months, if not longer. So I feel that vitamin D has quite a broad safety window based on that information. Yet nonetheless, if patients were going to be taking more robust dosages, like well above the typical say 2,000 or a few thousand IUs a day, then I think it is a good idea to have a lab basis for that. Would I, in my own comfort of my own home, potentially do a little bit of biohacking, see how I feel with some megadose vitamin D, just for good measure? Yeah, I would do that. I have done that, but is that something I'd recommend for patients? No, and it's a bit different when managing cases, but obviously folks can do whatever they so choose in the comfort of their own home. Next question here is, would genetic vitamin D receptor mutations predispose to this issue? My understanding is that is a prevailing hypothesis as to why folks might have vitamin D receptor resistance in the first place. So yes, I've definitely observed in clinical practice over the years that folks who have mutations, particularly in the VDR BSM location of the vitamin D receptor gene and the VDR TAQ location, I have noticed the pattern for years that those are the folks who tend to need much more supplemental vitamin D than the average bearer to feel as good as possible through the darker, non-sunny months that many of us have to contend with if we're not living in equatorial regions year-round. And then lastly, why would vitamin D cause flares in chronic patients? Could it be possible vitamin D lowering blood calcium and that increases circulating oxalates and the symptoms? That's a really good question. It's a good theory. Maybe. My rationale behind why vitamin D supplementation causing why vitamin D supplementation might cause a flare is because I assume that it's just upregulating physiological processes that the body's not ready for yet, similar to when I recommend B vitamins for a patient, or comprehensive mitochondrial support for a patient, or really any kind of therapy that's just generally should be good for the person. I feel that in some cases, if we build that therapy up too quickly, then it's going to be upregulating processes the body just can't deal with yet. The liver cells are like, oh, we have more energy, let's go do this work, and it starts getting a little overzealous. Or the kidneys say, oh, let's clear out some toxins. The tissues get overzealous. So it might be something to do with oxalates, and I like the way you think, and I'm all about like, oh, let's look at like the most complex mechanism possible, like biochemically, and I think it's really cool to be aware of that. And in many cases, it's good to like have a good sense of what what types of underlying complex pathways might be involved with a given clinical manifestation, because sometimes that is indeed the case. I look at it a little more broad strokes, and I can't say that I've seen a consistency of, oh, higher dose vitamin D causing symptoms that would be typically associated with elevated oxalates, although those symptoms can potentially be quite generic, like increased pain and fatigue, brain fog, things like that, but haven't really seen that play out in practice. But it's a really good thought, really good question. Thank you for the questions. I hope this video was of interest to folks listening. If anybody has any questions on this topic or anything else, just post in the comment section below, and I'll do my best to answer as soon as I can.